Morning, everyone. My name is Alejandro Lopez. I was diagnosed with osteosarcoma in December of 2023. I had a left below the knee amputation, and I've been NED for about 5 months. So today I have the pleasure of introducing Mr. Alejandro Sweet-Cordero. Dr. Sweet-Cordero is a cancer biologist and practicing pediatric oncologist specializing in basic and translational cancer research. His sarcoma research focuses on uncovering the mechanisms that drive osteosarcoma and Ewing sarcoma progression, metastasis, and therapy resistance. His team has extensive expertise in integrative genomic analysis, including whole genome sequencing, RNA sequencing, and ATAC sequencing, as well as functional genomic studies using CRISPR, Cas9, and lineage tracing techniques. These tools are applied to primary tumors, patient-derived xenograft models, and genetically engineered mouse models to drive gene and network discovery. In addition, Dr. Sweet-Cordero has significant experience in the real world application of tumor sequencing for precision cancer medicine and currently leads the Molecular Oncology Initiative at UCSF. Since June 2022, he has served as Division Chief of Pediatric Oncology at Marinoff Children's Hospital in San Francisco and Oakland. Get up for Mr. Alejandro.
So hopefully you all know how to pronounce Alejandro now. And if you don't, you can go listen to the Lady Gaga song. So thanks for that very nice introduction. So we have a wonderful panel today on a really, what I think is a really important topic. I think we've heard a lot at this meeting about tumor heterogeneity in osteosarcoma, both between tumor samples, and from the last session you also heard about intratumoral heterogeneity. And I think that that's something that we all need to continue to think about as we move forward, trying to find new therapies for osteosarcoma, the importance of identifying biomarkers that will help us to determine which patient is likely to respond best to what therapy. And I think that's going to continue to be a major theme in osteosarcoma research. And I think you'll hear a lot in this session about the progress that's being made in that area. So I'm going to introduce our speakers today. The first speaker is somebody who I know very well, Dr. Amanda Marinoff, who's spent some time in my lab and is now transitioned into doing more clinical research in precision medicine. And she's going to tell us about an effort that she's been leading together with several other investigators to try to put together an international working group to identify the best ways to stratify osteosarcoma patients using clinical biomarkers through this effort called cBOSS. So she'll be telling you about that, and I think that's a really interesting and exciting effort, and I think a good example of the importance of collaboration. And what's been impressive to me about that is just how fast that's come together over less than a year. That team has really made some impressive progress. So that's going to be followed by Dr. David Shulman, who's doing some very nice work using ctDNA as a biomarker. I think that that's something that's going to be more and more a part of our armamentarium, as you heard from one of the prior talks, and he's going to report to us on the LEOPARD study. That's going to be followed by the work of Dr. Masanori Hayashi, who is going to tell us about his correlative studies as part of the NPCF Phase II trial of gemcitabine and nab-paclitaxel for recurrent osteosarcoma. And then we're going to hear from our Italian colleague, Dr. Emanuela Palmerini. I'm excited to hear about her efforts to identify gene expression signatures related to mifamurtide response in localized osteosarcoma. And then last but not least, Matt Dietz, who's local here at the University of Utah, is going to tell us about the importance of MYC and the tumor microenvironment as a biomarker for osteosarcoma treatment. Without further ado, I'll introduce our first speaker, Dr. Amanda Marinoff.
Thanks for the introduction. Good morning. It's an honor to be here at my fourth factor and to be able to present our work on cBOSS, the Clinical Biomarkers for Osteosarcoma Stratification Working Group. And cBOSS was really activated at Factor last year when Ryan Roberts, Andy Livingston, and I sat down together in Cleveland and said, let's make this happen. And so I'm excited to share with you today what we've done so far and where we think we need to go next. I'll start by anchoring us in the central problem that really motivated this work, and that is, of course, that osteosarcoma is extremely heterogeneous, and yet our treatment remains one size fits all. We know that essentially all patients receive MAP, followed by surgery, followed by more MAP, regardless of their initial clinical presentation or their underlying biology. Now, this is not for lack of data. In fact, over the last couple of decades, there's really been a wave of publications nominating candidate prognostic markers that can really stratify survival for patients with osteosarcoma. This is just a screenshot of a Google search for clinical risk stratification in osteosarcoma. And what you see is so many Kaplan-Meier curves that, as Dr. Roberts says, you could really make wallpaper out of it. And yet, we're still not using any of these markers in our clinical practice to guide risk-adapted therapy or to tailor to the patient's underlying biology. And so this disconnect is what we really wanted to try and better understand and start to tackle with cBOSS. Here's a high-level overview of our goals. We wanted to evaluate the current landscape of prognostic and predictive biomarkers, which is currently fragmented, and we wanted to synthesize it in a systematic way that we could actually act upon. We wanted to build an initial framework for clinical risk stratification, prioritizing classifiers with potential for near-term clinical use. We sought to identify evidence gaps and unmet needs and build a roadmap for aligning future trials and correlative studies around shared priorities. All, of course, with an eye toward the holy grail of being able to implement precision medicine in our patients in the near future. I was privileged to work with a really phenomenal, truly interdisciplinary and international team spanning many domains of expertise and many institutions across the country, in Canada, and in Europe. And we got together every other week for a couple of months, sometimes at really early hours or really late hours, depending on where folks were in the 10-hour time difference, to review the evidence base for each evaluated biomarker, identify where we are in terms of clinical readiness and the gaps to try and get there for all of these. And here's an overview of the features that we evaluated. Certainly, we couldn't evaluate everything in the literature, but again, we were prioritizing those that we felt were able to be translated in the near term, and that spanned a number of domains, including clinical features, circulating tumor DNA, genomic, transcriptomic, and epigenetic features, tumor microenvironmental features, and a couple of therapeutic targets that we felt could help guide patient selection for targeted therapies in the future, including those on the surfaceome and the DNA damage repair pathway. And here's an overview of representative Kaplan-Meier curves that we evaluated for each of these biomarkers. And it's a busy slide, so I'll start by zooming out and draw you to the punchline, which is really that we see 8 different classifiers just on this slide, where the Kaplan-Meier curves, they separate quite nicely. And that tells us that we do have the data to stratify survival. But the fact that there are 8 fragmented systems just here on this slide tells us that we have some challenges for putting it all together and to implementing it clinically. To walk you through briefly each of these, A is a reminder that our clinical data is really important for helping us to stratify and should be layered on with our molecular data. The presence of metastatic disease at diagnosis remains the strongest predictor of poor outcome, and yet these patients are still treated like everybody else. B is looking at pretreatment circulating tumor DNA that we'll hear more about from Dr. Shulman next. C is looking at MYC amplification. We heard a lot about this in prior talks, and we'll hear more about it from Dr. Dietz later. D is looking at genome-wide loss of heterozygosity. E through G are 3 different transcriptomic classifiers coming out of the sick kids group, the French group, and MSK respectively. And H is looking at overall survival by methylation. And again, the central question is how can we actually translate these findings into treatment strategies that will improve survival and reduce treatment-related toxicities? To be able to tackle this big question, we first felt that we needed to establish kind of the state of each biomarker. Where do we currently stand and what are the gaps to clinical implementation? And so this is a simplified table summarizing the consensus category that our group came up with for each of these features. And we assigned 4 different categories, which are really somewhat fluid, but here I'll highlight that there were 2 stratification strategies that we think are ready for prime time that can be used to define eligibility criteria for subgroups in clinical trials. And that is clinical features in addition to stage, resectability, and primary tumor site, with axial and pelvic tumors being consistently associated with worse prognosis, and pretreatment ctDNA burden with the results of the prospective LEOPARD study. MYC amplification, we felt needed prospective validation due to challenges with determining a consistent cut point, and then these others required additional validation. And what that really boiled down to was that a lot of these studies, while promising, were done in small retrospective cohorts, usually with different patient characteristics, different platforms, different pipelines for analysis, and often different ways of actually defining the cut points or the biomarker itself, which again makes it difficult to compare apples to apples and synthesize this into one clinically implementable strategy. And so we identified a few key next steps and priorities to advance translation. The first is we clearly need to compare these classifiers across the data sets to identify, are these overlapping or do they provide complementary information that together would enhance our predictive power? As we validate these in retrospective and prospectively collected cohorts, we really need to be doing this in an integrated fashion, collecting multi-omics data to the extent possible, and importantly, linking these to clinical outcomes. We spoke yesterday in a great breakout session in cure-OS about kind of a minimal data set that we would want on all of our patients moving forward, so exciting to see that these efforts are now overlapping. We are recommending a shift to when feasible, whole genome sequencing and whole transcriptome sequencing based on some of the early preliminary data coming out of these transcriptomic classifiers and some based on more complex structural variants, and away from targeted panels, again, where feasible. And importantly, this needs to be adapted to the FFPE-compatible pipelines that are already embedded in our clinical workflows. In parallel, we need to prioritize clinical development of promising biomarkers for targeted therapies, and address key implementation questions in the real world, including how do we actually define these biomarkers, what cut points will we utilize in our clinical trials, and then of course the elephant in the room is how will we act on this, how will we treat our patients that we identify as high risk? Here's an attempt to start to answer this. This is a hypothetical risk stratification schema that we could imagine being employed in a future clinical trial where at the time of diagnosis, we're able to integrate clinical features with biology features and identify which patients are likely to respond to standard MAP therapy and which patients are likely to be failed by our current standard of care and really need to be put on trials or arms where they have the opportunity to receive novel therapeutic strategies. And on the other hand, they're starting to emerge across different data sets a subset of patients that seem to do really well. And so we can imagine that at some point they may be eligible for de-intensification of therapy or strategies that help to spare them some of the short and long-term toxicities associated with our current standard of care. I'll summarize this by saying we have the data to act now, and we're moving from discovery to implementation. And I want to close by just highlighting a few of the outputs that are already spinning out of cBOSS. We're in the final stages of our manuscript preparation, but it's been really rewarding to also see some efforts stemming organically from this, including our investigators sharing and comparing their institutional data already. We have proposals underway to collect specimens banked retrospectively and being collected on prospective trials. And efforts are importantly underway to develop standardized approaches for sample banking and molecular characterization, really upholding equity as a central pillar so that all patients, no matter where they're treated, have access to sequencing and to be able to benefit from the advances in precision medicine. And with that, I'll close and say thank you so much to this amazing working group, especially to Ryan Roberts for his vision and trusting me with a podium, to MIB agents for everything that you're doing, and and for inviting me to speak today, and to our patients and families who inspire this work and are partnering with us to make it better. Thank you.
Well, I would just like to start by thanking the organizers, and especially Christina, for the opportunity to present our data today. And really just to be here, Factor is really one of the weeks that I look forward to most now each year, and really leaves me feeling very energized and motivated, and for that I'm so appreciative. So with that, it's a pleasure to present updated data on pre-treatment circulating tumor DNA burden and associations with outcome from the LEOPARD study. Dr. Marinoff provided such a nice background. I'll be a little bit brief here as we start off, but to reiterate, identification of subgroups for evaluation of risk stratified therapy has remained a major challenge in osteosarcoma. Osteosarcoma is an aggressive bone sarcoma for which outcomes have not improved substantively in many decades. Stage and pelvic primary site are the strongest clinical factors we have right now. And we know this is a tumor characterized by an aneuploid genome with few recurrent single nucleotide variants that we could use for prognostication or targeting. There are relatively limited validated biomarkers right now, but as you just heard from Dr. Marinoff, there's a lot on the horizon, and that's really exciting. To illustrate why this is such a challenge, this lack of robust validated prognostic biomarkers has made it hard to develop risk stratified trials. And so you could imagine two patients who might present to a clinic like mine, one who has an osteosarcoma of the distal femur, another who has an osteosarcoma of the proximal femur. We might know something about their clinical features that would tell us one patient might have a higher risk of disease relapse after treatment, but undoubtedly the disease biology is likely different between these patients. Yet both patients will get MAP chemotherapy, they'll get local control, and then more MAP chemotherapy. And we know from historic studies that for a group of patients, they're likely overtreated, and they may have actually been cured with less intensive therapy and a good surgery, and then are left with significant late effects after treatment. There may be another group of patients for actually which this therapy is very well tailored. It gives them a very good chance of not having the disease come back. Late toxicity, but without it, they would have likely relapsed. And then, of course, there are patients where this is really just inadequate, and we give very toxic treatment, very aggressive surgeries, and unfortunately, tumors still come back after diagnosis. So the LEOPARD study was really designed to try and determine whether or not pre-treatment circulating tumor DNA was prognostic among patients with localized osteosarcoma. It stands for liquid biopsy in Ewing sarcoma, and osteosarcoma is a prognostic and response diagnostic. We opened the study in 2018, actually back when I was a second-year fellow, and we completed accrual to the osteosarcoma arm, which I'll focus on today, in March of 2023. This was, again, a prospective multi-center study. We had about 11 primary sites across the United States, and then collaborated closely with the Children's Oncology Group Project Every Child. The study included patients who were between 1 and 50 years of age at time of diagnosis. Patients had localized non-pelvic disease and had to be planned to receive standard chemotherapy. The study was powered to detect a roughly 20% decrement in event-free survival and required a minimum of 113 patients who would be evaluable for the primary analysis. We picked 3 pre-specified cut points based on preliminary data we had at the time the study was launched, including a 3% ctDNA cut point, which was the primary cut point, and then 2 secondary cut points, a 5% and 15% cut point. We evaluated on-therapy time points as pre-specified secondary aims in the study. And for circulating tumor DNA analysis, we used ultra-low pass whole genome sequencing for quantification of circulating tumor DNA, which has a lower limit of detection of 3%. And then we also used this for identification of copy number changes, specifically MYC amplification, which I'll come to later. Most recently, and I guess what's maybe new in this talk is that we also use fragmentomics-based size selection to try and be more sensitive at detecting circulating tumor DNA at those on-treatment time points. The study ultimately included 133 patients with evaluable disease, and I'll just note that about half of those patients joined through the primary study centers. There's a number of investigators from those centers here today, and there may even be folks who enrolled in the study. And then about half of the patients joined through Children's Oncology Group Project Every Child. And I know many investigators in the room have participated in Project Every Child, and again, there may be folks here who participated in that as well and contributed to the study, for which we are grateful. The other clinical and demographic features of this patient population are relatively standard for a group of patients with localized osteosarcoma. We found that circulating tumor DNA was detectable in 63% of patients at the time they were diagnosed. I think I went one too fast. There we go. Was quantified at a wide dynamic range, with the highest circulating tumor DNA levels at about 40%. We found that as patients moved through therapy, circulating tumor DNA's circulating tumor DNA burden drops with initiation of systemic therapy. And then by the time patients get all the way out on the right to after their surgery, all patients on the study had cleared their circulating tumor DNA. At the bottom, you can see that we've most recently used fragmentomics to try and be more sensitive at detecting circulating tumor DNA at the pre-high-dose methotrexate, pre-cycle 2, and pre-cycle 3 time points. We found that circulating tumor DNA was not significantly associated with the two clinical features that we've looked at so far, which are the presence of indeterminate pulmonary metastatic disease at the time of diagnosis, which is a frequent sort of conundrum when patients present, and then tumor size. In our primary analysis, we found that elevated baseline circulating tumor DNA was associated with event-free survival. So in our primary analysis for patients who had greater than 3% ctDNA at baseline, their 2-year EFS estimate was 56%, compared to patients who had low circulating tumor DNA at baseline, where the 2-year EFS estimate was 88%. We also looked at circulating tumor DNA as a continuous variable. So what does it mean as you get each percentage point higher of circulating tumor DNA burden at the time you're diagnosed? And this is a little bit sort of hard to think about intuitively, but the hazard for event goes up with each percentage point increase in circulating tumor DNA, and this is significant as well. We looked at whether or not on-treatment circulating tumor DNA burden was prognostic, so whether or not you've cleared your circulating tumor DNA prior to your first high-dose methotrexate. And while there was not a significant difference using our 3% cut point using the fragmentomics-based approach, in a small cohort of 43 patients, again, as a secondary analysis, we found that outcomes were worse among patients who had residual ctDNA at that time point. Most recently, we've tried to look at MYC amplification for the reasons you've heard from a number of other talks over the past 2 days. And we looked at the cohort of patients who either had elevated circulating tumor DNA at baseline and or available tissue for sequencing, which was ultimately 107 patients out of the cohort. We found good concordance in MYC amplification between tissue and plasma, and ultimately there were 23 patients who had greater than 7 copies of MYC, and that was the group we called as having MYC amplified disease. We found that those patients were more likely to relapse but did not have significantly different outcomes in this particular cohort, again, as part of a secondary analysis, and I think certainly one area of potential future study and discussion here at this meeting. So in conclusion, these findings prospectively validate pretreatment circulating tumor DNA as being associated with an inferior event-free survival among patients with localized non-pelvic osteosarcoma. Baseline ctDNA burden, we think, is now positioned for implementation into future therapeutic trials as a prognostic biomarker. And circulating tumor DNA detection prior to the first high-dose methotrexate may be prognostic but requires further study. Finally, MYC amplification as a composite biomarker in the study from tissue and plasma was not significantly prognostic in this cohort. So with that, I would really like to thank our Dana-Farber study staff, our very dedicated site investigators who stuck with this study over many, many years, and most importantly, our funders and the patients and families who've participated. Thank you.
First, I want to thank the organizers and MIB for letting me be here today, and also to the Novinsky family for supporting a travel award so I can be here at this meeting today. And also to Christina for putting together such an amazing meeting. All right, I'm going to present some results from a correlative study that we've done on the NPCF Phase II trial of gemcitabine and nab-paclitaxel for recurrent osteosarcoma. So the combination of gemcitabine and docetaxel has been used a lot. Sometimes we call it the GemDox. And nab-paclitaxel has preclinical activity against osteosarcoma, and there's some potential that it can reduce the myelosuppression that is commonly associated with the docetaxel. Osteosarcomas, we've talked a little bit about endpoints in clinical trials, but in osteosarcoma, sometimes even when responding to therapy, we see no change in measurable disease, and sometimes resist conventional method we use to assess for treatment response is not as effective for osteosarcomas. Also, we tried to look at some predictive biomarkers in osteosarcoma to see if we can assess response to therapy. My lab has been working on liquid biopsies for the past, whatever years, 8, 10 years. So we've been looking at circulating tumor cells, circulating tumor DNA, assessed by multiple methods in peripheral blood. And we're trying to use this more as an alternative to tumor biopsies to identify and also track disease characteristics. So the NPCF study, MCC 18613, was a Phase II trial of gemcitabine and nab-paclitaxel for recurrent osteo. Patients were aged 12 to 30. They came in with relapse or refractory osteosarcoma and had to have measurable disease. Both nab-paclitaxel and gemcitabine were administered on a standard schedule. And then correlative studies, importantly, we collected circulating tumor cell samples and circulating tumor DNA every 2 cycles. And circulating tumor DNA was assessed by standard ultra-low passage whole genome sequencing. So the clinical side of the results, we had 18 patients enrolled, median age of 16. The median number of prior chemotherapy was 2 regimens. 2 patients experienced a confirmed partial response, and 6 patients received up to 4 cycles. 6 patients required dose reduction, and 3 were removed due to toxicities. The median progression-free survival was 1.9 months. 5 patients out of the 18 eligible patients were progression-free at 4 months, and therefore the progression-free survival at 4 months was 28%, which was statistically significant compared to the historical control. So getting into the correlative study section, so the circulating tumor cell detection was done based on a cell-sieve filter system. This is a system that we've been working with a company called Creative Microtech in Bethesda, Maryland, since I was a fellow, so almost 10 years ago. We published this in multiple papers. They've been using, they also have a research lab in the company, and they've published this in breast cancer and other carcinomas, but also we've published it in several studies in sarcomas. The difference with previous circulating tumor cell detection methods is that it's a primarily size difference, which can overcome the fact that sarcomas in general do not express epithelial markers that are standardly used for carcinomas. So the circulating tumor cell detection of the cohorts, now that I'm standing here, it's such a small font right there. But so here we saw that there was a loose correlation with increase of circulating tumor cells with progressive disease. The shaded boxes are the time of progression. And while it is hard with this kind of number of patients to make a conclusive conclusion based on the numbers, there is a correlation that seems to be that if you start having increasing of circulating tumor cells, then there is, you can predict progression there. And then in ctDNA with ultra-low passage, we had several patients who had detectable ctDNA. We're rather surprised that multiple patients did not have detectable circulating tumor DNA, perhaps because they're heavily treated. I think Dave presented some data that once you start treatment, a lot of your ctDNA does drop, and these patients do come in after multiple treatment cycles. I think notable is that the 8 patients who had detectable ctDNA that came into the trial progressed rapidly, and then 5 of the 10 patients with negative ctDNA at baseline responded. So I think this goes along with the previously known data that when you have ctDNA, there is some prediction you can make. And then I think MIG has come up a lot with this in this meeting, and since we use ultra-low passage method and look for copy number aberrations, we can look at specific gene amplifications. We find that MYC amplification is the most common finding among these patients, which perhaps is not surprising considering that it has been indicated as a negative predictor of outcome. And also, I think earlier there was a talk about clonal evolution that has shown that over the time, resistant patients develop MYC amplification clones. So in conclusion, this is a small subset, but with relapsed osteosarcoma, had some clinical benefit from the combination of gemcitabine and nab-paclitaxel. Circulating tumor cells appear to be better suited to detect disease progression, while ctDNA detection can yield molecular disease characteristics. That's obviously hard to get in circulating tumor cell enumeration. Completely separate project. We've been working on circulating tumor cell single-cell RNA sequencing, and obviously you can't do single-cell RNA sequencing for every patient for cost reasons. The patients enrolled in our cohort were recurrent refractory osteosarcoma patients, and the high rate of MYC gain and amplification is very consistent with what we've learned from previous studies. Right now, the NPCF is running a prospective biomarker study, MCC20320. I wish I had a slick name like LEOPARD, but we'll go with the numbers. And we've completed enrollment of 60 newly diagnosed osteosarcoma patients. These patients get about 10 time points of blood draws throughout the treatment, and also off therapy, up to 12 months off therapy. And we're now following the patients and seeing what happens in this trial. And then CTC and ctDNA detection is the primary endpoint of this trial. And I would like to acknowledge people in my lab who did a lot of the hard work on this. Also, the National Pediatric Cancer Foundation, Lars and Javier, who were the PI of this study, and also all the patients who participated in this multi-center study, and also all of our funders, also my collaborators and mentors over the years. Thank you.
Good morning, and thanks, Christina and the MYC factor agent for this opportunity to present this data on prognostic and mifamurtide-related signature in localized osteosarcoma. This is a correlative study of ESGOS2 trial, which will be published next month. So I think it's a very good opportunity to discuss it today with you. These are my disclosures. So there are several signatures. Oh, Christine, I think it's the wrong one. Yeah. Sorry for that. Anyhow, there are several, can you change it while I'll discuss about this? Okay. So there are already several signatures, including the French sarcoma group signature, which were done on a complex group of localized and metastatic patients. So we decided to perform this study specifically in a localized patient within a group. Another different, our methodology is specifically designed to target tumor microenvironment. So we will use nanostring technologies which address more than 770 genes specifically underscoring the environment. And with this technology, we asked ourselves two questions. Can we identify the strong prognosticator in patient localized at diagnosis? And also, can we use this signature to underscore which patient will respond better to mifamurtide? Mifamurtide is a drug approved in Europe for the treatment of localized osteosarcoma. It targets macrophage, so it's a specific macrophage activator, and it is not very much used because of its cost. It's a cost both in terms of price. It costs more than 140,000 euro per patient, but it's also a cost in terms of patient quality of life. A patient have to go to the hospital to receive mifamurtide twice a week for the first 3 months, and then 6 months weekly. So it is a drug that requires a lot of in terms of quality of the time of the patient. So it's very important to find out a rule to give this drug. So going back to the other signature, so this is the signature of the French group, and it was this month published a study validating the signature, again in a metastatic and localized cohort. This is the Italian sarcoma group study. As you can see, mifamurtide is given in a biological stratification way. So only patients at high risk for being PGP positive would receive mifamurtide. And the results were updated in this study, which included almost 400 patients of the Italian sarcoma group and the Spanish sarcoma group. In this post-hoc analysis, mifamurtide showed an improvement in both event-free survival and overall survival in the high-risk group. So we believe that there is still a role of this drug in patients newly diagnosed with localized osteosarcoma. And as I said, so far, only about 10% of prescribers prescribe this drug. This is a survey conducted within the Foster Fight Osteosarcoma through European Research Consortium. And the reason is the high cost of this treatment. So we got together the Istituto Ortopedico Rizzoli, where I used to work, University of Bologna, and also the European Institute of Oncology in Milan, where the nanostring technology was used. We identified this group of 62 patients, and all were non-metastatic, and the median age was 14 years, with the older patient being 40. This is the technology. So as I said, 770 genes were assessed, all evaluating the tumor microenvironment. And the problem with the bone tumor is the decalcification process, but non-decalcified tissue is a good tool to assess genome, and we use non-decalcified tissue. So the primary endpoint to the prognostic signature on 62 patients, and the secondary endpoint, the mifamurtide-specific signature. We were able to identify a strong prognosticator with a 5-year overall survival for low risk of 92% as compared to 47% of patients with high risk. And this is the cutoff of 2.4, identifying 21 genes in this signature. And all these genes are implied in T cells trafficking and inflammation, in particular CD99, which is responsible for T cell migration, and also ABC glycoprotein was confirmed. Importantly, this prognostic factor was independent when we compare with all the other prognostic factors, and was validated in 2 series. The first, TGCA series, and the second, it's Eurobonnet series, all selecting localized osteosarcoma patient at diagnosis. Also through CyberSort-X analysis, we asked ourselves if this signature identify different population. As you can see, at diagnosis, most of our patients were enriched in M1 and M2 macrophage, but also B-cell naive, while the expression of other markers like NK and especially CD8 T lymphocyte is highly heterogeneous. We found out that patients at low risk of progression and death had a high infiltrate of CD8 cells, but also T regulator and NK at diagnosis, while patients with a very high risk of progression and death had CD4 lymphocyte infiltration. These data, I think, are important, and we should try to address the drugs that change this tumor microenvironment. And the original part of this study is all the mifamurtide-specific signature. Again, we were able to divide the patient in mifamurtide-sensitive and mifamurtide non-responsive. This signature is composed by 31 genes, and most of the genes are chemokine receptor 2, 3, and chemokine ligand 10, all implicated in immune cell trafficking. Again, this signature was strongly independent from other prognostic factors like histologic response, age of the patient, and phosphatase alkaline. Importantly, the prognostic and the predictive signature do not overlap, with only 5 of the genes present in both signatures. So to conclude, a validated tumor microenvironment-based signature was identified and validated in other series obtained with whole genome sequencing. So the tumor microenvironment has a important role in osteosarcoma. A mifamurtide-specific signature was identified, which need to be validated. And this tumor interaction should be definitely studied to target tumor progression in osteosarcoma. And in the future, we can use mifamurtide in a specific subset of osteosarcoma patient based on this data. And I want to thank all the investigators, patients and their families, and my mentors, Dr. Ferrari and Dr. Picci, in this picture, which were the primary investigator in this trial. And of course, all the team at the Istituto Ortopedico Rizzoli. And I thank you for your attention.
Great. I'll keep an eye for the slides to come live. But as that happens, I'll just say thank you for the opportunity to come here and talk to MIB agents. This is just a really beautiful forum, so thank you. We'll talk about the prognostic significance of c-MYC in the tumor microenvironment and in osteosarcoma. And I'll just say that Jane Underdown, who's not here, she's 2 weeks postpartum, did a lot of the work that I'll present from Colorado. And with that, I'll get us going. Osteosarcoma needs no introduction to this group, and we've certainly had a lot of discussion of c-MYC here. This is a transcription factor that regulates a lot of gene expression. It's involved in, estimated up to 70% of cancers, and that's largely through overexpression or amplification, and is associated with poor prognosis. We know that there's a subset of patients with osteosarcoma who have c-MYC copy number gains, and this is currently, there's just mounting evidence that c-MYC is associated with a poor prognosis in osteosarcoma. And I think one of the things that we can see is if we look across a lot of these studies, there is variability in what materials are being assessed, whether that's protein, RNA, DNA, how they're being assessed, like methodologically quantified, and then what cut points or thresholds are being set. And across the studies, you can see some materials having discrepant results at the DNA or at the protein level. And so Jane looked at a set of common osteosarcoma cell lines and looked at c-MYC through Western blot for protein expression, as well as FISH for copy number. And here you can see that there are examples of discordant findings, for example, in the 143B line where there's high protein expression, but no evidence of amplification. And then did some targeting of c-MYC, first using JQ1 to look at the targeting transcription regulation, which I know may not be MYC dependent, but then also looking at targeting the protein interaction of MYC with MCI 975. And what you can see here is that 143B, a high protein MYC, grew throughout JQ1 treatment, but responded to the MCI inhibitor, which targeted the protein interactions. And I think this kind of can underscore the importance of thinking about how we develop MYC as a biomarker, as a prognostic biomarker for what materials we use, and then also with the kind of emergence of MYC inhibitors as a predictive biomarker for who may respond to agents. And so kind of thinking about those therapeutic approaches to MYC, obviously there's lots of oncogenic effects from this transcription factor, and the approaches therapeutically to target really are indirect and direct, both at the transcription at the protein level. Another thing, if we look at the effects of MYC, as Rebecca mentioned yesterday, is there's an element of tumor microenvironment and immune modulation. And so this would be another potential indirect way to exploit MYC expression or amplification in tumors. And so this is an ongoing project that we have that kind of came together from Colorado and Oregon when we both landed in Utah. And our goals are to evaluate c-MYC at the protein level with IHC, as well at the FISH level, at the copy number level with FISH in human osteosarcoma specimens, and then to describe the tumor immune microenvironment in MYC dysregulated specimens. So the cohorts, we have a cohort of 80 patients from Children's Hospital Colorado, that were identified basically in the past 20 years. And then a cohort of 75 patients from Oregon Health and Science University, again, over a 20-year time period. We used FISH, and these were at least the initial amplification definitions, with high level being a ratio of 8 greater than 9 copies of MYC to the centromere part of chromosome 8. And we'll evaluate c-MYC expression with H scores and have digital pathology and pathologist review of that. And then our multiplexed imaging has a small panel of immune markers. And so, if we look at just the clinical characteristics of these two cohorts, the OHSU cohort has a little bit older population. We had both pediatric and adult specimens in there, so a little over 60% of the patients were less than 18 years old versus almost all of the Colorado children's cohort. And then relatively expected distribution for tumor necrosis, and I'll just point out in the Colorado cohort at the time of the analysis, there were 10 patients alive with disease, and that analysis was last done in 2021, so those numbers might look different, now. So for the FISH assay, we identified specimens that had c-MYC amplification, which is represented in that first box, where you can see lots and lots of red signals and very few green signals, which is the control probe, and then the lower box, which shows kind of an equal distribution of red and green signals. The Colorado cohort, there was a fair amount of specimen failure, 24 of the cases, but we know that working with this tissue is very hard, especially archival 20-year-old tissue. But 23% of the cases, or 12 patients, were identified as having high amplification. In the OHSU cohort, and this is kind of pretty fresh, there was 8 failures, and this is just with like a QPath analysis, so it hasn't been validated by a molecular pathologist, but 15 cases with high expression. If we kind of just look at the clinical data from that Colorado cohort, the bulk of these were biopsy specimens. All of the OHSU ones are biopsy. Patients got chemo and surgery, as you would expect. And then if we take patients and look at them kind of as either c-MYC amplified or not, you can see that there is an enrichment in having a metastatic burden at diagnosis, developing metastases, developing relapse and dying of disease. And then when we looked at the OHSU cohort, we haven't gone through all of that yet. We could see in the MYC amplified that of those patients, there was increased risk for death, but the other clinical features we haven't gone through yet. And this is all obviously univariate analysis. The protein level work is ongoing. Here are a couple examples of just immunohistochemistries with positivity or negativity, as well as the immunofluorescence panel, with the pink being c-MYC. And it kind of gets to a question that I asked yesterday about thinking about the localization of MYC and how to quantify it, nuclear, cytoplasmic, other whole cell. And most of those are actually completed at this point in time, and we're just pulling that the analysis of those slides. And we can certainly find discordant specimens already where there are FISH amplification and no protein expression, or vice versa. As part of that coming back, we are getting some of the immune signatures in the tumor microenvironment, and these are really just a couple of specimens that are back, but we can see in some correlation between c-MYC expression and PD-L1 expression, which has been described in literature, but really kind of too early to say too much on that front. But I think we'll be positioned to describe the lymphocyte compartment as well as the macrophage compartment. So next steps in this work, obviously we have to complete the analyses that we've just started here. And then because these are clinically annotated sets, we'll be able to do multivariate analysis, as well as evaluate kind of correlation between protein and copy number, and then complete the tumor microenvironment analysis. And I think I expect that we'll find that there are differences in the protein level and the DNA level, because we've seen that in other studies already. And this, while frustrating, also gives us an opportunity to explore why is that? Is there a biologic process that's underpinning that would be important? And then work that's ongoing to evaluate this prospectively. And with that, I'll say thank you to everyone, to patients and families, and to the variety of institutions that have kind of contributed to our paths here and our funders. Thanks.
Great, well, thanks to all our speakers and for staying on time. We have lots of time for discussion. So if anybody wants to ask a question.
Thank you. Question for Dave. This is the first time I'm seeing the MIC coming from the LEOPARD study data. That's really interesting. So noting that LEOPARD wasn't powered to detect a difference in MIC amplification, are there other technical considerations that you could elaborate on for us non-biologists? And then follow-up question, are you looking at raw MIC copy numbers for your cut point, or are you looking at a ratio between MIC copy numbers and, is it chromosome 8 copy numbers? Someone more biology, help me. Amanda's nodding, I'll take that as a yes.
Thank you for the question, Natalie. I do think there are probably multiple like technical considerations that you could use to hypothesize for why the results from that cohort are different than some of the other cohorts we had seen. We did this analysis on the back of Dr. Marinoff's paper, and so I had looked at that and talked to Dr. Janeway, and that's how we selected that second copy, 7 copy cut point, and that's really just the like raw copy numbers from the ultra low pass whole genome sequencing. So I think we don't know for sure if that's the like right way to look at that. We also haven't looked at MIC expression, and again, that's different from some of the other cohorts because we used a composite biomarker that really tried to enlarge the cohort by both looking at it from circulating tumor DNA and from tissue sequencing. There in the full cohort, there was 133 patients with ctDNA, but just under 100 who had tissue. So yeah, I think there's multiple potential reasons for why the results have not looked the same as other cohorts.
I just want to make a comment on that. I think we need to all remember that when you look at copy number using something like ctDNA, it doesn't. There's kind of two ways that you can have amplification. You can have an ecDNA that gets reincorporated into the chromosomes that can be scattered throughout the whole genome, or you can have an HSR which is localized in one place. And I think biologically those might be very different. And I'm curious, Matt, whether you've looked at that in your immunofluorescence, whether you see kind of a scattered pattern as opposed to a focused pattern. Because when you have a scattered pattern, the level of expression of MIC could be very dependent on where the insertion happens, right? So I'm just curious whether you've looked at that.
It's a great question, Alejandro, and something that we're actively doing. A happy accident that happened, because I do a lot of this with the core facility, is they also did RNA scope on all of this for cMIC, so now we have that as well as FISH, and so that is an active part.
I'd like to ask Dr. Shulman about the LEOPARD study. Congratulations. But a couple of things expressing my ignorance first. Please explain what percent means, percent of what, for example. Number 2 is justify your stratification based on a 5-centimeter tumor size when the standard accepted classification is an 8-centimeter cutoff. And then just a technical point, do you consider pelvic tumors axial or extremity in your analysis in the LEOPARD study?
Yeah, great questions. So the percent ctDNA comes from, again, using low passage whole genome sequencing. So this is usually between 0.5 and 1x sequencing of the whole genome. And then we use an algorithm called I-Core, which is used across a number of different malignancies that gives you an estimate of the amount of DNA in a particular plasma sample that we think is coming from the tumor versus coming from germline DNA, and that's validated down to 3%. So it's really looking for copy number changes across the genome, and then trying to compare that to germline sequencing. We selected 3% as the primary cut point because in 2018, we had published another cohort from the Children's Oncology Group of about 74 patients, where we found that particular cut point, which is really undetectable versus detectable with that assay, was prognostic. And so that's what the whole statistical plan was written around that particular cut point. The 5% and 15% were meant to estimate the median, which was a secondary cut point. That was on the extra slide that I didn't show. And then 15% would be the 75th percentile, really trying to identify the very highest risk patients. I'm sorry, I've now blanked on your other questions, but I think you were...
Tumor size.
You're asking about tumor size.
Tumor size, stratification at 5 versus 8 centimeters.
Yeah, we certainly could look at 8 centimeters. We could look at it as a continuous variable. The point of doing that was really trying to determine whether or not circulating tumor DNA is sort of independent of tumor size, and then...
Sure, it makes total sense, except for the fact that the other's an established stratification. That's all.
Yeah. So we certainly could look at 8 centimeters as well.
Thank you.
Yeah, a question that's actually very similar to the first one from Laura up there. It occurs to me, I'm sure to many people sort of sitting here, thinking about the studies with the ctDNA and prognosis, very similar to minimal residual disease 30, 40 years ago in leukemia. And so we're catching up. The question, and we'll probably hopefully talk about it again at the clinical session, the last session today, is what's it going to take and what will it look like to actually incorporate the ctDNA as if it's MRD in leukemia and start to actually make it standard of care, not just a clinical trial, but standard of care. What are the steps we need to take and how can we push that forward even faster? Anyone can answer.
I feel like I've spoken a lot, but I'm happy to give my thoughts on that. The way I think about moving a biomarker from something that you're studying in the laboratory in a sort of preliminary hypothesis testing cohort to actually really changing outcomes is sort of starting with laboratory validation. So can we reliably measure this biomarker in a set of samples? Clinical validation, can we reliably identify different prognostic groups, ideally in a prospective cohort, to say that this group of patients has this outcome and this group of patients has this outcome. And then really the next step, I think, is asking a question that's ultimately going to lead to what Dr. Marinoff started this session with. How can we improve cure rates and reduce toxicity? I think actually the cBOSS outline for sort of where each of the prognostic factors are is really nice to say what's the closest to designing a clinical utility study where you can really improve outcomes. I think for the sort of like MRD piece, if you're trying to say like after 3 weeks of treatment or 4 weeks of treatment, what does it mean to have some residual biomarker of disease? I hope that we can catch up to ALL there, because I think that's actually probably going to be more important than pre-treatment circulating tumor DNA or maybe some of the other things that we're looking at, just quantifying ctDNA, but I think needs more work.
Sorry. Pre-cycle 2 ctDNA measurement is part of the secondary endpoint in the 20320 trial. So we model it after the ALL, post-induction MRD. So so hopefully we'll find some data from that prospective trial that could lead to seeing us change treatment if you have positive ctDNA pre-cycle 2.
And also, I think that to move also to move all these signature into prospective trial and gain on survival, we need active drug. What we were trying to look at with the tumor microenvironment is the reason of this bad or good prognosis. So I think that most of the implementation would imply a new drug that can change that and then randomize patient on those drug or not. But the next foster trial will use both G1, G2 signature from the French sarcoma group and also will also use circulating tumor DNA. So baby steps are already done. And to respond to the patient asking for mifamurtide in US and in the metastatic setting, there is a trial ongoing in France for the mifamurtide in metastatic osteosarcoma, but the results are not ready yet. In the US, probably it's going to be difficult, but it must mainly depend on the possibility to validate the signature and then maybe to go back to the drug company.
I have a follow-up question to that, Dr. Palmerini. Yeah, so your mifurtamide signature, can we learn anything from that regarding like possible combinations with mifurtamide that may work better, or maybe the status changes in the myeloid compartment that the drug is actually doing so that we can see maybe it's just mild and we need to like work like on that axis harder or something? So like,
yeah,
if those questions
also
make
with
sense.
chemotherapy. I think that immune environment modifier or T-cell trafficking modifier are being developed in several solid tumors. So I think that combining them at newly diagnosed osteosarcoma patient harboring that signature would be important, and the randomized trial to answer this question is should be implemented. And also to respond to Dr. Leo Mascarenas, yes, the signature was independent from chemotherapy because it was independent for tumor necrosis, and the chemotherapy was assigned based on tumor necrosis.
Yeah, I just want to add a little bit of a framing comment and kind of a challenge to the community, and that is, I think that we know that about 10 to 20% of our patients we're totally overtreating because they would have been cured with just surgery, right? And we know that about 40% of our patients, our treatment is inadequate, right? And they need something either different or more. I think we pursued more a lot and had a lot of frustration. Maybe what they need is something different. And then we've got the rest that are in the Goldilocks zone, and that's just fine. But we have a lot of tools now to be able to kind of start sorting that out. And I think that our history of frustrating clinical trials has made us reluctant to push things from the clinic into the clinical space, from the lab into the clinical space. And we need to be less reluctant to do that as a community. And there's examples of things like this moving forward. And I think that as we push these things forward, we really need to be guided by that framework of who are these patients that we need to change our treatment on. Because some of the changes that we probably should make, we already have, especially for those patients that are doing very well. And so we need to be braver in pushing those things forward.
Yeah, I have a question for Dr. Shulman about ctDNA. And unfortunately, I think the answer to my question is no, but I'm going to ask it anyways. I asked the same question to an employee of the ctDNA company from the Boston area, and they said yes, absolutely, but they may be biased. And the question is, can ctDNA be used as a surveillance tool for patients that are NED and possibly detect a recurrence before the formation of a physical tumor shows up in CT scans?
So I think that's a really fantastic question. There were some nice data presented from patients with other types of sarcomas at this year's ASCO meeting. Actually, I unfortunately wasn't at the meeting, but just looking at the abstracts using tests that were more sensitive than the tests that I presented here. Again, in other sarcomas where there were cases where they were successful in detecting recurrence earlier. I think this is like a super important question to ask. From the LEOPARD study, though, we don't have the answer to that. There were many surveillance samples submitted on that study that we've sequenced. I did not present those data here. And often ctDNA is positive at time of recurrence, but we didn't see sort of signals that this assay is really good at picking up recurrence early. It also wouldn't really be the assay that I would predict would be best for that. And that's because this was really designed to be a tumor-naive assay that can detect high levels of circulating tumor DNA to really try and identify patients with high-risk disease at diagnosis. I think the assays that are going to get us there are going to be tumor-informed assays where you're looking at a patient's sequencing, you're finding some modest number of variants that you can track at a much more sensitive level in the circulating tumor DNA, like the SAGA test or the Signatera test from Natera. But before we know that, I think we need more data. So I hope someday we're there.
I was just going to comment on Laura's comments in the chat. Laura, it's a great question. What are we actually going to use as MYC amplification as the definition? I think when we put the paper out initially a few years ago, we thought it would be a pretty simple, it seems like MYC is an answer, we just need to validate it, and then we'll implement it. And as we've seen throughout this talk and with Matt's work, the validation studies are also using different cut points, different platforms, and they're not all concordant. So I don't know exactly what the answer is. I think there may not be a very clear cut point. We maybe need to evaluate things in a more continuous fashion. And then I think we can potentially leverage the fact that we're doing more multi-omics level data and saying maybe it's an or question, maybe if we detect it at the DNA level or the RNA level or at the protein level, that all puts you in a category where you could be eligible for higher risk therapy. Matt, I'm curious to hear how you're thinking about this.
I would actually largely echo just what you said, Amanda, and not that the COG is responsible for doing all of the things, but I do think the molecular characterization initiative is such a good opportunity right now with the possibility to try and use NGS and kind of newly diagnosed patients and FFPE tissue, something that will be highly generalizable as in the future, and all of the work to optimize tissue procurement and avoid decalcification. I think this would be a great use of that platform.
Thank you. My question's for Dr. Palmerini. Do you think the tumor microenvironment signatures that you've shown will have any relevance to predicting response to CAR T cell therapy or NK cell therapy or other types of immune cell therapies?
That's a good question. I think that CAR T therapy for osteosarcoma probably depends on the payload and on the target, but definitely if CD8 immune response is modulated for those specific CAR T, might be a good stratification factor to get tested, a diagnosis. Very good suggestion. Thank you.
Dave, I'm kind of intrigued by your comment on the tumor-informed next-generation assay for osteosarcoma. I mean, in ALL, this works well because there's a barcode on each of the cells, but here we have a tumor that multiple people have shown is continuing to change, and you may lose that barcode. What are you thinking of targeting for that, and how would you ideally design that assay?
Yeah, I was hoping nobody would ask that. I think it's a great, I think it's a really, really good question for osteosarcoma. In like, Five years ago, I would have just said, for example, the Signatera panel that looks for SNVs is not going to work for any sarcomas. But there's like more and more data coming out that actually you can find variants that are sort of reasonably close to early variants that are not so subclonal that you can track them. But I think you could take two approaches. You could see if you could find enough of those variants in sort of the majority of patients that you could follow them, and they haven't sort of disappeared at time of relapse. And then this other assay that was sort of presented at CTOS, the SAGA assay, uses structural variants. Signatera does whole exome sequencing in there, so they're only looking at variants in the exomes, and then have some algorithm to try and say if they're important things to follow. But I think the other possibility would be using structural variants. There's a lot of other things on the horizon, though. I mean, there's like methylation sequencing. So I do think there will be a solution for osteosarcoma. I don't know exactly what it will be.
Can I just, I think also when we talk about ctDNA, what's released by the tumor is somewhat dependent on the biology. So there's nucleosome-bound ctDNA, there's transcription factor-bound ctDNA, there's different ctDNA that comes from different parts of the genome. And so I think we don't know, it's an ongoing field right now to figure out what is actually coming out and what is the most sensitive of this. And I think a lot of the studies that people are doing right now on tumor evolution is even, because it's going to be very tumor context dependent. So tumor evolution, I think, will pinpoint to whatever gene and whatever area is the most, it can't just be just one gene too. Depending on where it is, what would, and then maybe we can figure out a ddPCR assay that could track patients, but it's going to be, we need a lot more knowledge about tumor evolution.
We're running out of time, so maybe we'll take one more question and wrap it up.
Thank you, sir. Kurt Weiss, Pittsburgh. One quick question and two comments that I will also make quick. So the question, I hope, is easy. Forgive my ignorance, I'm not a gem guy. What is the phenotype of the c-MYC knockout, or is it embryonic lethal?
MYC is a required gene. You can't live without MYC. MYC is a required gene. You can't live without MYC.
Oh, okay.
Yeah.
Okay, cool. The comments, so to extend off of Dr. Palmerini's comment about the use of mifamurtide in metastatic patients, is there any evidence to support that? I mean, Dr. Kleinerman's in the room, she can correct me if I'm wrong, but I'm pretty sure that 100% of the phase 1 and phase 2 patients had to be metastatic. So I think there's nothing but data to support that. And then as a springboard to Dr. Roberts' excellent observation, clearly it's doing something, right? We've got the Spanish data, the Italian data, our own data. When are we going to figure out what to do with mifamurtide? I know I'm as biased as it gets, and I'm not ashamed of that at all. But I think that's another discussion for this group.
Thank you.
Any final comments?
Yeah, I think it's a great point, and I've been discussing for many years. I know that there are still some patients being treated with mifamurtide also in the United States, and I think improving the therapeutic window and seeing the data in the metastatic setting might give new hope to this drug.
I was just going to pivot back to a question that Dr. Ladle put in the chat about whether we would be brave enough to not treat a patient with metastatic disease with MAP. And I think it was Mark Twain who said the definition of insanity is doing the same thing and expecting something different. So I think we need to be at least a little bit brave and do MAP plus something different and give ourselves that opportunity.
Okay, well, thanks to all the panelists for a wonderful presentation and lots of great discussion.